I'm the moderator for today. I'm one of the nurse practitioners in the NP interest group with RNAO. So welcome today to NPIG Insider. So this is a monthly webinar series for NP members of RNAO to network, share, learn, discuss, as well as collaborate on various topics that are relevant to the NP practice. And this month, in response to interest and relevance of the topic, we are welcoming all our NAO members to the call. And just a reminder that webinars are the fourth Wednesday of each month from 5:30 to 6:30 p.m. So today, I do want to introduce Sue Faber. She is an RN, as well as a co-founder of the not-for-profit organization Lyme Hope, as well as a co-author of the RNAO Nursing Resolution Patient First Treatment for Ontarians with Lyme disease. So Sue has been invited to testify as a witness at the Parliamentary Standing Health Committee at several public forums, as well as educational events in Canada and the U.S. And her colleagues have been advocating for Canadians at the federal level, as well as working with various elected officials and the Public Health Agency of Canada to highlight issues that matter most to Canadians, as highlighted in this resolution. So she currently sits as a member for the Canadian Association of Schools of Nursing Climate-Driven Infectious Diseases Advisory Committee, as well as representing RNAO, and is a very strong patient advocate. Sue is passionate about uniting and empowering nurses, physician researchers, and of course other allied health professionals with the common goal of holistic, evidence-based, patient-centered care and research. So again, thank you, Sue, for joining us today in discussing challenging the Lyme paradigm.
Thank you so much for having me. I really appreciate. Can you hear me okay?
Yes, I can hear you clearly.
Okay, perfect. Okay, I'll get started. So thanks to the Nurse Practitioner Interest Group for inviting me to speak to you this evening. I also want to thank Doris Grinspun for her incredible leadership of the RNAO. And she's really inspired me, and I know she's inspired all of us from across Ontario, Canada, and globally with a critical message of empowering nurses to advocate and speak out about issues that matter not only to our patients, but to our own professional practice. I really trust this presentation will give you a bit more insight into Lyme disease, ranging from the importance of listening, engaging, and advocating on behalf of patients to digging deeper into research. I'll be highlighting current and historical peer-reviewed literature and evidence which exists on different aspects of Lyme, including chronicity of infection, in utero transmission, problems with current testing, and more. I don't have any conflicts of interest to declare. I am a registered nurse, and I did my training at McMaster University, graduated in 2001. What was most important to me about my training at Mac was problem-based learning. And for those of you on the phone who went to Mac, and I'm sure other universities use this approach as well, but I really feel that it has provided me with a platform to be able to do the advocacy work and the education that I'm doing today. We have a real problem on our hands with Lyme disease, and there's many reasons why. This disease has become so stigmatized and controversial, and many people actually shy away from it. Nurses and indeed all frontline healthcare professionals have a tremendous opportunity to dramatically help the health of Canadians and change the current landscape from one of despair and marginalization to one of hope and meaningful action. So this is the Patient First resolution, which was carried in May 2018. It was a collaborative effort. It was co-authored by myself, Catherine Kinsella, and Dr. Luella Nenenko-Rankin, who's the president of the Halton Region Chapter. I'll never forget the moment the resolution was carried. I honestly couldn't stop the flow of tears because I knew that this important document would be a platform which would affect change for patients all across Canada and actually around the world. So what are Canadians most concerned about? And I'm going to be sharing a little bit more with you about how we determined these concerns. But what they're most concerned about is not consistently receiving appropriate diagnosis and treatment, lack of education and awareness amongst healthcare professionals, issues around persistence and chronicity of infection, transplacental transmission or in utero transmission, and that's my area of expertise, and significant advocacy. Issues around concerns around sexual transmission. There's not a lot of research on this topic. It's definitely something that needs to be investigated. Blood supply issues, needle stick injuries, organ donation. These are all issues that advocates have raised as being that they're very concerned about. We also know that Lyme disease has been politicized. and it's created fear and uncertainty and hesitancy and reluctance amongst healthcare professionals. Patients are often denied referrals to specialists, and which is really disturbing, and they're often forced to pay out of country for assessment, testing, and treatment. What we really need is for patients to be involved in a collaborative patient-first clinical model. So this next slide is really important to me because it's all about patient-relevant clinical research and patient engagement. And as we go on, what's really important to Lyme patients all across Canada is for them to be included at the very beginning in all steps of research as it relates to Lyme disease. So for those of us who are involved in research and maybe in research projects in the future related to Lyme, we have to remember that the patient is first and we have to listen to them. That's absolutely critical. This is an important slide to me by William Osler. Listen to your patient. You know, he is telling you the diagnosis. And when it comes to Lyme disease, patients have not been listened to. In fact, this disease is tangled in so much controversy that patients have suffered, been ignored, ridiculed, and denied appropriate care. The Latin root of patient is patir, which means to suffer. And there are many Canadians who are currently suffering, and you're going to hear more about that in a little bit. This slide, I love the Cochrane collaboration, and this is Victor Montori, and he talks about evidence-based care is not about the evidence, but about responding to patient problems with evidence. And then you see this Venn diagram about evidence-based medicine by Sackett, Dr. Sackett, and he talks about the importance of equal contribution of clinical judgment, relevant scientific studies, and patient values and preferences. So a little bit more about myself. Why do I care so much about Lyme disease? Well, I'm a patient myself, and as are all three of my daughters. A bit more about my personal story is available on the RNAO website, on the Registered Nurse Journal, the April-May edition of last year. But to put it in a nutshell, after 15 years of seeing multiple subspecialists with all kinds of symptoms, I was finally diagnosed with Lyme disease in Canada. I didn't have a bullseye rash. I had never pulled off a tick, and so I had never considered Lyme as a differential diagnosis. My symptoms ranged from severe fatigue to atypical chest pain, spontaneous floaters in my eyes, migratory pain, crushing bone pain, my foot that would drag on occasion, brain fog. I actually thought I had early onset dementia. I couldn't remember my children's birthdays. It was horrendous. So I had to undergo every diagnostic test, and everything was always negative. And, you know, at the very end of it, I was told, Sue, it must be that you have depression and anxiety, and it was recommended that I see a psychiatrist. But I knew that there was something wrong, and so I continued to push. And then eventually I was tested for Lyme, and I was, I guess, one of the lucky ones to test positive. So after my diagnosis, I started to do research. This disease was steeped in so much controversy, and even my infectious disease doctor didn't want to use the word chronic Lyme disease with me, even though that was exactly what was wrong. I had a chronic, disseminated, undiagnosed infection, which had wreaked havoc on my body. And it was actually during this process of research that I came across initial case reports on in utero transmission and how the agent, Borrelia Burgdorferi, could be transmitted across the placenta of an infected mother to her baby. This is where my heart just sank, because all three of my daughters had been sick from birth. They'd all had strange symptoms just like mine. So we ended up having to take our girls to the U.S. for testing. All of them had Western blot tests come back positive with IgG antibody evidence of exposure to Lyme disease. And later on, one of my daughter's tests came back positive by an ELISA here in Ontario. And because I had a European strain of Lyme disease, I figured that if she was infected in utero, it would only make sense, rational sense, for her to have a European strain as well. However, there was a roadblock. The only way for her to get a European test was for her to have a recent travel history to Europe. And so I had no choice but to lie on the requisition that she had a travel history to Europe. Her symptoms had started shortly after birth, and they progressed in frequency and severity: night terrors, sensitivity to touch, OCD, strange macular papular rashes, debilitating anxiety, crushing headaches, bladder issues and incontinence, terrible pain in both her ankles. We had seen specialists for her as well, and we were just told she had patellofemoral syndrome and anxiety. Anyway, a long story short, was her test came back positive, and you'll see on that slide that the first two tests are myself, and underneath you'll see my daughter's test. Both came back positive. And she also came back positive for a European strain. So as a result of her positive test and my concern that this could be in utero transmission, I called the local Halton Region Public Health Department. And I was actually kind of excited. I said, look, I think I might have a case for you of a maternal fetal transmission of Lyme disease. And they weren't too interested in talking to me about it. And I did have a 30-minute phone call with the chief medical officer at the time, and she suggested that if I had any further concerns that I follow up with my family doctor. And my family doctor didn't have any, have any knowledge about Lyme disease, so that was really a no-go. About a month later, I received this letter, and if you look at your screen, you're going to see that they write me this letter, and it's actually very, very concerning because I'm told that even though I have two-tier positive serology in Canada, both myself and my daughter for European strain, that we are not going to be counted in the statistics. And I was just shocked by this. And they went on to say that the reason we weren't being counted was because our symptoms were atypical and nonspecific, and we didn't have a clear onset date or a reliable travel history to Europe. And so they wouldn't count us as even a probable case or a confirmed case of Lyme. And I was just shocked, and I thought, this is horrendous. What's going on here? To make matters worse, the second page of their letter, because I had brought up in utero transmission and congenital Lyme borreliosis with them, and I had done quite a bit of literature searching at that point, they actually addressed this, and you'll see this on this slide. And they said, although a significant amount of research was conducted, no scientific evidence to support congenital Lyme transmission in the scientific literature was found. And then they actually gave me a list of the evidence that they had reviewed. And what was even more shocking was that two of the papers in their list were the seminal articles discussing in utero transmission and congenital Lyme disease. And I tried to call them and say, look, can I have another meeting? We need to talk about this. And they said no. So this is what really got me going. As was mentioned in my introduction, I was called as a witness to speak in front of the Standing Health Committee at Parliament, and I just about broke down into tears as I was sharing my story and my concerns about in utero transmission. This is a 10-minute recording that is available on our website. It's also available through the Parliamentary HEPA Committee. But this is where I started ringing the alarm bells and saying, look, there's evidence about in utero transmission. This needs to be addressed. So this next slide here is one of my favorite sayings. And, you know, in the journey that had started for me at that point, I knew that I was equipped as a registered nurse, as a mom, to act and speak out, not only on behalf of myself and daughters, but on behalf of other Canadians who are also suffering and marginalized and ignored. So I decided to take action. And I thought to myself, okay, who would be the best person for me to meet with to talk about my issues? And so right away I thought, well, I need to speak with the Minister of Health. So I did a little Google search and I found out that it was the Honourable Jane Philpott. And I also found out that she was having an open house in her local constituency in, I think it was January 14th, 2017. And so anyway, I thought, okay, well, I'm going to go and meet her. And I wasn't her constituent, but I figured I would just drop in and see if they would let me in. So I wrote a 17-page letter. It took me 2 days to write this letter, and I just waited while I wrote it, and just sharing our whole journey up to that point. And by this time, I'd also heard from many Canadians who had similar stories, so I inserted some of their stories as well. And I actually ended up having an opportunity to meet with her for 10 minutes at that constituency meeting. And I started sharing my concerns, and she was very responsive and very warm and engaging. So as a result of that, literally that very night, I went home, and I said to my husband, you know, this is so important that patients be able to share their stories. And so I started the Lyme Letters campaign. And I put out a call through social media, and so here you can see the Lyme Letters Canada. This was a letter that I put out basically through Facebook, And I went the next day to Shoppers Drug Mart and opened up a P.O. box. And basically what I was saying to Canadians who were concerned or affected by Lyme is write your letter, address it to the Minister of Health, and I will personally hand deliver all the letters. So just a little bit more background. Patients have been speaking out for many years across Canada, the U.S., and around the world, lobbying local, provincial, and federal politicians. In May 2016, there was a conference to develop a federal framework on Lyme disease. And here you'll see pictures of different patients who were invited from all across Canada to come and share their personal stories. The conference was mandated by Bill C-442. It was a private member's bill authored by Elizabeth May. And this was the first national opportunity for patients to speak out. The question is, were their voices heard? So back to the Lyme Letters campaign. My P.O. box started getting flooded with letters. And over a period of approximately 7 months, I received 2,700 letters that kept flooding in. The letters were devastating. They were written by men, women, and children. I read every single one of them. I actually invited a group of other support, I call them support staff, but these were just other moms like myself who had Lyme disease, and I said, look, I need help to read these letters because we need to identify the common themes. And Catherine Kinsella, who co-authored the resolution with me, she was a huge part of that, and she came and helped me read through these letters and identify common themes. And then in February 2017, the government posted a draft framework, and this was a result of that conference that I just shared with you. And this draft framework was horrendous. We were just shocked by the content. And so myself and my colleague and co-founder Jennifer Kravis, we decided to jump into action. We started a petition on change.org, and it's called the Ticking Lyme Bomb Petition. And within days, thousands of signatures were being added from all across Canada. And I think right now we're close to 83,000 signatures and counting. We also collected over 15,000 personal comments, and we organized them by province and town. So in April and May 2017, we decided that we needed to travel to Ottawa. And you can see those suitcases there. They are full of letters from patients all across Canada and their caregivers. So we were able to get meetings with MPs and senators and other officials from the Public Health Agency of Canada. And here you'll see a picture. This is Elizabeth May. She's actually reading through the petition comments, very concerned. Here's a picture of just meeting with some of the MPs and senators. I think we've had personal contact with over 50 MPs in Ottawa, over 10 visits to Ottawa in the past 2 years. In May 2018, we were invited to go and speak to Conservative Party leader Andrew Scheer and his senior cabinet members, and that was another very important meeting. And I was really excited because I was able to share the resolution at that point as well. Here's just a picture with the Public Health Agency of Canada. These are all the senior executives there. And you'll see everybody's wearing a cap. And those were just little Lyme Hope hats that we gave them. So that's why they're all wearing little white hats. You'll see here, this is a meeting with the Minister of Health, Christine Elliott. So we met with her, also very concerned and, hearing from her constituents as well. And this is what's so important, is kind of reaching out, provincially, federally, locally, at a municipal level. And so we're, have been trying to do that ongoing. In May 2018, we met with MPs at an all-party roundtable in Ottawa. And you'll see the woman sitting closest to you in a tartan jacket. And she actually reached out to me. Her name is MP Diane Finley. And she said, Sue, my constituents are in Haldimand, Norfolk, which is highly endemic for Lyme disease. And I've heard so many stories from them. Will you come and do town halls in Haldimand, Norfolk? And so we were invited there, and was just overflowing with people from the community coming and sharing their stories and desperation. And from that town hall, we were invited to go and speak with the Six Nations community in Ohsweken. So speaking out is really important to us. And most recently this past week, some of you might have seen, but CTV National News featured our story on, I think it was on Sunday night, and then we were also interviewed Monday morning. Just one other piece I want to show you, and this is an article done by Ann Kingston. She's a senior journalist from Maclean's magazine, and so she featured our advocacy work. And the title of her piece was "How the Impatient Patient is Disrupting Medicine," and how patient activists have never been as vocal, but are they actually being heard? And I believe us within the RNAO, we know what it means to be a disruptor, especially if we're disrupting the status quo. And that's something that's very important when it comes to what's going on with Lyme disease. So now I'm going to go into an overview of Lyme disease itself. I'm going to be taking you at a rather quick clip through this. There's lots to cover. And the purpose of me having so many slides is because I just want you to kind of see how significant the body of literature is around some of the issues that I'm going to be sharing with you tonight. So what is Lyme disease? It's a bacterial infection caused by a corkscrew-shaped spirochete called Borrelia, named after the scientist Dr. Willy Burgdorfer. So Borrelia Burgdorferi, named after Dr. Willy Burgdorfer. There's different Borrelia species that cause Lyme disease. The North American strain is Borrelia burgdorferi, and then there's Borrelia acellii and Borrelia guerinii, and there's many other strains as well around the world. It's the most common vector-borne disease in the U.S. and Canada. And the CDC actually estimates 427,000 new Lyme cases per year. So this is a huge number. In Canada, it was 2,025 new cases. So there's a real disparity between what's being reported in Canada and in the U.S., and I think there's a significant underreporting, which I'm going to be talking about shortly. There's actually a recent paper published by a scientist and a senior clinician, and which reveals that only 3 to 4% of Lyme cases in Canada are being officially diagnosed. So how is Lyme transmitted? Well, most typically by bites from infected ticks. Studies have shown it can be carried by flies and mosquitoes, but transmission risk is controversial. Then, of course, there's mother-to-baby transmission, concerns about blood supply and organ donation, and this is definitely an area that requires research, and then the concerns of sexual transmission as well, which requires research. So this report came out in 2012, and there was this ice mummy dubbed Aussie, and they actually found the Lyme disease bacteria through genetic analysis of this mummy. And so that tells me that Lyme disease has been around for a very long time. It's not just a brand new or emerging disease. It's been here for a while. There's different stages of Lyme. It can be acute, which is, after a tick bite and the disease, there's this EM rash that may or may not be present. So that's the acute stage. Then there's early disseminated, and then there's late disseminated or chronic Lyme disease. And all this information can be found on the Public Health Agency of Canada website, so you can, look a little further into what these symptoms are. And I believe you'll be able to have access to these slides again for further research if you like. So Lyme disease can affect every system in the body, and the immune system, heart, muscles, brain, eyes, nerves, and joints. And this nice little chart from LymeDisease.org actually lists chronic versus early Lyme, and you'll see what the differences are there. One thing that's really important to note is that Borrelia Burgdorferi infection, it can affect many systems at the same time. So, for those of you who have patients that are coming to you that have multiple system complaints, and they're saying one day, I've got this migratory joint pain, plus I have, weird memory issues, plus I'm not sleeping at night, and I've got numbness and tingling in my fingers, and there's even a lot of concern with sexual dysfunction. There's all kinds of things that can go wrong, cardiac issues, bladder issues. The list is long. This questionnaire is absolutely critical. It's called the Horowitz questionnaire, and I recommend that all of you go online and download it. And what the Horowitz questionnaire does is a screening tool. And this doctor, Dr. Horowitz, is an internist from New York, and he's compiled common symptoms found in patients with Lyme and other tick-borne diseases. It identifies and weights these symptoms, and then you get a score, and the higher the score, the higher the likelihood of tick-borne disease, including Lyme disease. So who is at risk for Lyme? Well, it's everybody, absolutely everybody. And this is a picture of all the signatures on our Lyme petition. And you can see that there's Canadians coast to coast who are identifying either they have Lyme disease or they're concerned about Lyme disease. So we also know that ticks are spreading rapidly. We also know that ticks can spread through migratory birds. So Lyme is not just isolated to certain endemic areas or endemic maps. You have to remember that, especially for a patient that comes in who might be way up north and you're like, well, okay, the Lyme-carrying ticks aren't that high up. But we have to remember that they could go anywhere because of migratory birds. There was a paper that came out in 2012, and it said that by 2020, 80% of Eastern Canada will be living in tick-infested neighborhoods. So that's quite concerning. We did we asked a professional opinion survey firm to do a Canadian benchmark survey for us, and we asked this question: have you or someone you know in Canada been diagnosed with Lyme disease? And the answer was 4 million Canadians. So this is significantly different from the 2,000 that we saw that was reported in 2017. So here's some pictures of ticks. I want to highlight the green arrow of it's a little boy, and he actually had a tick embedded in his gum line. So these ticks come in tiny little nymphal ticks all the way up to the bigger ticks. And but just to be aware that oftentimes people never feel a tick bite, they never see the tick, and oftentimes they don't have an EM rash either. So please do not rely on the 24 to 36 to 72-hour rule. It really changes what you hear of how long a tick must be attached for to transmit infection. There was a published review that was done in 2015, and I have the citation there for you. And the review actually stated in conclusion, the minimum attachment time has never been established. And another review came out from the Pasteur Institute in France, and they actually found that Borrelia-infected nymphs were able to infect mice as early as 12 hours after tick attachment. So it's also not just Lyme, but you can also get co-infections. So ticks are nature's dirty needle, and people can simultaneously be infected with multiple infections with one bite. And some of these infections include Bartonella, Babesia, Rocky Mountain spotted fever, Ehrlichia, anaplasmosis, Q fever, murine typhus, and many more. And almost all of these co-infections can also be tested for on the public health requisition. This is a paper from 2018, just came out, very interesting. And they say that 65% of Lyme disease patients also have other microbes, so some of these other co-infections that I've just spoken about. Another interesting thing that they showed in their paper was that 72% of the individuals, or 3/4 of the individuals, were classified negative by the CDC two-tier test, but were positive for Borrelia with a persistent form, which I'm going to be talking about a little bit later. Here's some pictures of EM rashes. You'll see they come in all shapes and sizes. They do not have to be 5 centimeters or greater to be an EM rash. They can take different forms. Typically, they're known as the bullseye rash. What's important to note is not everybody gets a rash. And if you do get a rash, it's confirmatory that you have been infected with Borrelia Burgdorferi and you need to get immediate treatment. It's also important to note that you do not, if you see a client that comes in with an EM rash, do not test them for Lyme disease at that point, because very likely you can test them, but don't wait for the test to come back before you treat them, because it takes time for antibodies to develop, and you don't want to wait for this disease to disseminate before you treat. I'm not going to be talking about treatment today. That's outside my scope, but I will be sharing a little bit more about some treatment guidelines in a few minutes. There was a study that was done early on in Lyme, Connecticut, which showed that only 25% of patients had an EM rash. Okay, so it's quite significant. Here you'll see just some other EM rashes as well. The rash, which has multiple circular rashes, that is a sign of disseminated infection. Now, this is a picture of my daughter, Andrea. These are EM rashes that showed up on her. They came out of nowhere, and you'll see that they're kind of blanched in the middle and red on the outside. These came and disappeared very quickly over a course of about 2 hours, and were confirmed by my pediatrician as secondary transient migratory EM rashes. This was before she was diagnosed with Lyme disease. Lyme disease is also known as the great imitator, and oftentimes people are diagnosed with other syndromes or symptoms. And yet what you'll find is that the peer-reviewed literature identifies many of these other syndromes or diseases as, some of these patients actually do have Lyme disease. So it's very important to take a closer look and to ensure that your differential diagnosis also rules out Lyme disease, potentially causing some of these neurological conditions. Psychiatric Lyme, this is a big deal. So a lot of patients will present with neuropsychiatric symptoms. I'm not going to go into detail here, but there's an excellent tool on the ILAD website on psychiatric Lyme, which I recommend that you go and take a closer look at. Suicide in Lyme. Lyme has been linked to higher rates of suicidality, and that's something that is of grave concern, obviously. So, these patients who have all these neuropsychiatric symptoms that just start out of nowhere, you've got to take a look at could there be underlying infectious etiology. This is just a study that was done in children, and Lyme disease in children may be accompanied also by long-term neuropsychiatric disturbances. So another very important study. Let's go into Lyme testing. So there's different modalities for testing. Currently in Canada, we use a 2-tier test or serology test. We're looking for antibodies. But there's other tests that are available, including an ELISpot, which is looking for an immune response, a cell-mediated immune response. PCR tests can be ordered and done, I believe, at the Public Health National Laboratories. And then there's culture. Now, there's really no culture modality currently available in Canada. This is a 2-tier algorithm. And so it starts with an ELISA test, and if that is positive or equivocal, then you go on to a Western blot test. This is a monograph from the ELISA, and it's very important to point out, they state very clearly that negative results should not be used to exclude Lyme disease. And oftentimes patients, when they get a negative result, their healthcare provider will say, well, it's not Lyme disease because your test was negative. This is just an example of what a Western blot strip looks like. And a Western blot makes a map of the different antibodies the immune system produces to the bacteria. Lyme disease must be a clinical diagnosis, and a negative test result does not mean you do not have Lyme disease, and there could be many reasons for this. Some of these could be that there weren't enough time for the antibodies to develop, that you have seronegative Lyme disease, which has been well described in the peer-reviewed literature. The immune system might be suppressed, sequestration of antibody to Borrelia Burgdorferi and immune complexes, so therefore you won't get a positive test. The patient may be infected with a strain that the test doesn't measure. Early antibiotics might abrogate the antibody response, or the patients don't have Lyme, but they might have other infections. So this is a paper that just came out in Canada by Dr. Lloyd and Hawkins, and very interesting paper. I highly encourage you to take a look at it. And they are indicating that only 3 to 4% of Lyme cases are officially being diagnosed using the current 2-tier testing criteria. The Government of Canada has information on their website for healthcare professionals, and they list 3 different international treatment guidelines, and I recommend that you take a look at that. I certainly advocate for the International Lyme and Associated Diseases Society treatment guidelines, and one of the things that the ILAD strongly recommends against is the use of a single dose of doxy for the prevention of Lyme disease. And you can take a look at their website to get a bit more clarity on that. I'm going to very quickly in the next few minutes talk about persistence of infection. So Lyme disease has been proven in the literature to persist. And most recently, in March 2018, a researcher from Tulane University, Dr. Embers, she did a study on primates, and they infected 10 primates, and they treated 5 of them I think it was 4 months after the infection. And what they found was quite shocking, that only one of the 10 primates that was infected displayed a rash. The primates started being like an ape. Only one of them, one of 10 displayed a rash with central clearing. And what they also found was that rare but intact spirochetes were found in tissues of both treated and untreated subjects. This is a study going back to 1993, talking about persistence of infection. And again, another study where they actually were able to find Borrelia burgdorferi in a ligament of a patient, and they were able to isolate it. Again, talking about persistence of infection. This paper was very interesting. They took urine of patients with chronic symptoms, and they discovered that 72 of the 97 patients had DNA, Borrelia burgdorferi DNA by PCR. Another study that is more recent in 2016 identifies the DNA of Borrelia burgdorferi. They cultivated Borrelia burgdorferi strains from antibiotic-treated persons, suggesting active infection with persistent Borrelia may be the cause of recurrent symptoms. So there's over 700 peer-reviewed articles that support evidence of persistence of Lyme and tick-borne diseases, and those can be found on this Google Drive, which you can take a look at later. Borrelia is known to be pleomorphic, and that means that it can change form. And this is also very important because if it can change form from the spiral shape to a typical cyst shape or granular form, then it can also escape antibiotics. So Dr. Tim Lewis, he did this study out of Northeastern University, and he talks about how some of these cells are persister cells and they're alive, but they lie dormant in a spore-like state. And then once the antibiotic has been flushed from their system, then they wake up and they can multiply again. Another similar finding by a professor from Johns Hopkins University, and this one was a concerning paper by Judith McCloskey, where they actually found Borrelia burgdorferi in these different pleomorphic forms and cystic forms in the brain of chronic Lyme neuroborreliosis, and again, talking about persistence of infection. So the last 5 minutes, because I want to leave 10 minutes for questions, I'm going to be talking about Lyme disease in pregnancy. And this is my area of passion and what I've been lobbying the government and speaking to many people about. So can Borrelia burgdorferi be transmitted in utero? Well, the simple answer is yes. If you look at syphilis, syphilis is taxonomically related to Borrelia. They're both spirochetes. And what we know about syphilis is that mothers are tested for syphilis, and one of the reasons for that is that syphilis can be asymptomatic. And you can still have syphilis and be asymptomatic and still transmit the infection to your baby. And this is one of the concerns I have about Lyme disease as well. Recently, the Public Health Agency of Canada did a systematic review on gestational Lyme disease, and myself and my colleague were actually involved in this review. We reviewed their draft document, and they actually report transplacental transmission and adverse outcomes in this review. It's a very important read. Now, Canada actually reported on transplacental transmission in 1988, so that's 31 years ago. And this was shocking to me because most physicians and other healthcare professionals I knew had never heard that Lyme disease could be transmitted other than through a tick bite. Public Health Agency of Canada on their website does not mention the risk of in utero transmission, and this very much concerns me. I don't understand why not. We were involved in a multidisciplinary roundtable on Lyme disease with the Public Health Agency of Canada, and participants actually raised this as a significant area of concern, and I'm really thankful that they did. So this is definitely getting on the radar. In France, the National Assembly also reported maternal fetal infection as possible. And the current edition of Remington and Klein, which is an infectious disease textbook, actually lists Lyme disease. You'll see it there. The acronym is TORCH is CLAP, and they're replacing the acronym TORCH to TORCH is CLAP. And what they're talking about here is that Lyme disease is under L, is one of the organisms that can be transmitted from mother to baby. And then they go even further to, you'll see that in the yellow circles, that they do list Borrelia Burgdorferi as being able to cause congenital disease in the infant. Dr. Charles Ray Jones actually treated my children and is an incredible physician, pediatrician. He's over 90 years old now, and he's still treating children from all over the world. And he lists multiple system symptomology in children born with Lyme who are congenitally infected. And I realize I'm going through this very quickly, but you'll be able to have access to these slides later on so you can take another look. The CDC also discusses that Lyme disease may lead to infection of the placenta and possible stillbirth. And the March of Dimes in the U.S. has also listed complications of Lyme in pregnancy, especially untreated Lyme disease. The CCBR, an author, Dr. Todd Hatchett, who's the current president of AMI Canada, he did report on transplacental transmission as well. And the NIH reported in 2005, I believe, on transmission. Infection can be transmitted to your unborn child. And so this is well known that this infection can be transmitted mother to baby. I'm going to quickly go through these case reports. These are the early case reports that showed that Lyme could be passed, and these were done with upon fetal autopsy. This is the first one from 1985. This is from Europe in 1986. There were 2 more cases. Spirochetes were seen in the fetal tissues. This is a physician from the U.S. who made it very clear. It is clear Borrelia burgdorferi can be transmitted in the blood of a pregnant woman across the placenta into the fetus. The WHO reported on transplacental transmission in 1986. Dr. Burgdorfer himself, who discovered Lyme disease, also highlighted that it could be spread transplacentally. And this was a case report that he authored. Another case report, this time culture positive but seronegative. The mother's serology was negative. So this brings up significant concerns, because if a mom is seronegative, how are we going to identify that she has this disease and potentially could pass this on to her baby? And this is a significant issue that I brought forward to public health agency officials. Another case report from Europe, again, a baby who died after birth, and Borrelia was recovered from this little baby's body. So there's so many of these reports, and I'm just going to scroll through a few more because I just don't have time to go through all of them. But again, they are going to be available on this deck. Here you'll see Borrelia spirochetes identified in tissues, fetal kidney and heart. And here was Borrelia spirochetes found in the brains of infants who succumbed to SIDS. And so there's a question of whether or not this could be a concern with SIDS. There's one here on neonatal Lyme disease presented in 1989. And authors from that case report said the importance of treating women with Lyme disease quickly so that to prevent congenital transmission to the fetus. Another report, again, discussing vertical transmission has been demonstrated and the concerns. Case report from Austria. This is a whole family suffering from Lyme disease and asking about sexual transmission and in utero transmission. Another one from Italy, a baby who's born and develops these rashes and has to get multiple antibiotic treatments because the rashes keep reoccurring. And this is an entire textbook, an entire chapter of a textbook by a leading pediatric infectious disease doctor who was very concerned about congenital Lyme and was trying to start a case definition for the disease. One of the things that she identified was that serology in the baby might not be a sensitive method of diagnosis and will lead to misdiagnosis of a majority of congenitally infected infants. Another case report from 2003 out of Germany, and Russia is another report. So there's just so many of these reports. They are all a lot of them are case reports, but very important to note. There was a document that came out, another study that came out in 2010, which showed a statistically significant association between untreated Lyme disease and adverse outcomes in pregnancy. And most recently, a physician, an obstetrician and gynecologist, has also reported on transmission of Borrelia, and that it can occur via zoonotic vectors as well as human to human, and that congenital transfer is an established fact. So how do you know if an infant is infected with Lyme? Well, negative serology does not indicate lack of infection in the infant. And so you're going to need to do things like PCR on the cord blood or infant blood or PCR RNA sequencing. There's all kinds of different testing modalities will have to be used to test an infected baby. So next steps, there's lots of next steps. I mean, my area of focus is in utero transmission. We are actually partnering with an incredible researcher, Dr. Vet Lloyd from Mount Allison University in New Brunswick, to do longitudinal family studies using direct detection methods to isolate Borrelia in blood and urine samples of family members. So that will be coming down the pipeline very soon, and we'll be making announcements about that study shortly. I have done a whole presentation on pregnancy and gestational Lyme, which you can access on our Lyme Hope website. It goes into more detail about some of these case reports and studies, just for those of you who are interested. So what are next steps? I realize I've gone through this very quickly, but at Lyme Hope, we are actually committed on providing some educational events on Lyme disease and bringing in Canadian and international experts to speak on the subject matter in more depth. And so we will be making those arrangements, and those will probably be happening in the next year or so. It does take some time to pull that together, but we'll certainly let the RNAO know when those educational seminars will be available. And on our website, we have all kinds of handouts which might be helpful to you, just basics on Lyme disease prevention, symptoms and treatment, co-infections, and then the literature that exists on transmission. So that's the end of my presentation, but I just want to thank you for giving me this opportunity, but also just sharing the importance of speaking out. And when issues come to the forefront, whether they be Lyme or something completely different, just powering nurses to do something about it and to take a step forward. And I truly believe that we can be instruments for significant change on behalf of Lyme disease and those who suffer in Canada. Thank you very much.
Thank you, Sue, for sharing your personal story. It's unfortunate that it took so long to come up with a diagnosis, but it really does speak to the importance of really having an accurate diagnosis as well as be adequately treated, as well as emphasizes the importance that us as a healthcare practitioner, that we do really listen to our patients as opposed to just defaulting to a diagnosis of mental health when all your tests comes back negative. So does anyone have any questions for Sue?
All right, I'm just going to add, if you want to ask a question and you don't want to speak, you can type it in on WebEx at the chat box on the right-hand side, and I'll be able to read that out. If not, you can go ahead and ask a question over the phone. You don't have to say your name if you want to ask it anonymously.
I do have a question if no one else has one yet, but why do you think there's such few research regarding Lyme disease with respect to vertical transmission, despite all these, I guess, anecdotal evidence so far?
That's a really good question. I don't know the answer to that. There were some epidemiological studies that were done back in the 90s in the U.S., and really there's nothing been done since in terms of longitudinal studies. But it's a very good question, and I have the same question, actually, that I ask. And that's one of the things that I am, going back to the Public Health Agency of Canada with. And we're also going to be working alongside the Society of Obstetricians and Gynecologists. And so I'm hoping that there'll be some new opportunities for some research that will answer some of these questions a bit further, for sure.
That would be great.
Yeah, yeah.
Is there any other question? We probably have time for about one more question.
It's Brenda Horton. I'd just like to say thank you very, very much for this great educational opportunity. To be able to ask you very many questions, I'll have to really have a good look at your website because there's so many small questions that I'm sure will be answered with all the information that's already there. But thank you very much. I plan to get into your website and have a good look at this.
And one of the things I do want to highlight is I'm more than happy to be for you to reach out to me. You can certainly get my email address through RNAO, and if you have any more specific questions, and I can also link you to practitioners and get answers from experts in the field with regards to specifically treatment, because I know I'm not talking about treatment of Lyme disease because that really is outside my scope as an RN, but I'm certainly more than happy to direct you to other resources with specific questions you might have.
Thank you. That would be great.
There's a lot of controversy with Lyme disease, and it's something that really bothers me and disturbs me, that it is so controversial, and I really believe that we can kind of bridge that. There's like this gap that currently exists, and so that's something that I'm absolutely committed to doing, and just keep moving forward, and I really believe that nurses can lead the way on this. One other thing I want to share is that I've done several much shorter presentations and much more kind of focused presentations on Lyme disease with several nursing groups. So if you have a group within your own hospital or organization that would be interested in a presentation in the GTA, that would be something that I would be more than happy to come and do a lunch and learn with those individuals. So please keep that in mind for any of you who would like myself to come in and do a more focused presentation. I'd be more than happy to do that.
I would be interested in having a focused presentation on diagnosis and treatment.
Yeah.
And perhaps with the NPIG, we could set that up again, because this is really it's a wonderful opportunity to learn, and it's a terrible thing to miss something like this.
Yeah, absolutely, and
the opportunity to diagnose and get treatment for a client, because obviously the signs and symptoms are so diverse that it could very easily happen, right?
Absolutely, and that is something that we do want to set up. Is like a one-day conference where we can have presenters come in, physicians come in specifically to speak to diagnosis and treatment. I think it's absolutely critical. So yes, I'm hoping that this presentation just kind of whets your appetite for some of the issues that do exist, so that we can kind of start thinking a little bit broader about what some other questions are that need to be answered and where our knowledge gaps are.
Great. Well, thank you very, very much, and I hope you get all the answers you need for your children and you get the right treatment.
Thank you. We're in the right direction, that's for sure.
Good.
It's a very interesting topic. I didn't realize the symptoms were so diverse. I can see how sometimes the diagnosis can be missed right off the bat. It's very interesting. Okay, so I just have a few closing remarks. Thank you again, Sue, for your advocacy, and thank you again for presenting on Lyme disease. So next month we do have the NPIG Insider again. It's going to be on February 27th, and the topic next month is going to be on NP fellowships. And then again, I just want to remind people about the NP Institute. So RNAO is hosting the NP Institute from March 19th to the 21st at Niagara-on-the-Lake. So it is open to all NPs as well as NP students. So the early bird pricing ends on Friday the 25th. So just take a look at it, make sure that you put in some abstracts if you're interested in presenting, and then make sure you get your submissions in by 5 p.m. on January 25. So that's it. Thanks again.
Okay, well, thank you very much.
Thank you, everyone. Thanks. Have a good night.
Okay.